Ladies and gentlemen, you are all welcome to this lecture in which I will be discussing the management of a stroke. And we would start first of all after reaching the emergency room, because we have identified already the stroke by the FAST. And F, as we have mentioned in the last lecture, stands for the face, the asymmetry of the face, the deviation of the mouth, and A for the arm drift, S for the speech abnormality, and T for the telephone call for the emergency medical services. So in the ambulance or after reaching the emergency room, then airway, breathing, circulation, temperature needs to be tackled. And here, regarding the blood pressure, I would like to mention something which is very important. If the blood pressure is high, there is no necessity to put it down, as it increases both morbidity and mortality. Unless the blood pressure is more than 220 over 120, that's only the time which intervention needs to be taken. Otherwise, we are going to observe the blood pressure for up to 48 hours before doing any intervention. And this has been shown, if you drop the blood pressure instantaneously, this has been shown to increase the penumbra, which is the area of ischemia that hasn't undergone necrosis yet. And all this rush is that we are going to save this area by thrombolytic therapy. We are going to prevent its progression to necrosis. So that's why even blood pressure should not be dropped instantaneously. Then the blood glucose, both hypoglycemia as well as hyperglycemia, have been shown to increase morbidity and mortality in patients with acute stroke. And in all our patients, we have to treat both of them. Whenever one of them occurs, then it has to be treated abruptly in a timely manner. What about hydration? All our patients with the stroke and even those with intracerebral hemorrhage needs to be well hydrated, and their mean arterial pressure should be kept above 65. Then we come to specific management of those patients. All this rush is that we are trying to save the ischemic area by thrombolytic therapy. Unfortunately, in the best centers in the world, like in the States, for example, where statistics is very much important and it's available, only 30% of their patients are manageable by thrombolytic therapy, while 70% come after the golden hours, which are usually 3 hours, but now recently it has been extended up to 4.5 hours, since this is the period in which there is a great improvement of both neurological deficit, a reduction of morbidity and mortality. So if the patient falls outside this time, then probably aspirin would be the best treatment. In all patients, we have to guard against deep vein thrombosis by using heparin. Coagulation profiles needs to be checked and managed appropriately. And we have to manage all the risk factors for stroke, like dyslipidemia, by giving statins. Diabetes, as we have mentioned, we have to keep it well controlled. And then carotid endarterectomy for those patients in whom Doppler ultrasound revealed carotid artery stenosis. Of course, it depends on the extent of the stenosis. In patients in whom the carotid artery occlusion of more than 75%, then it's quite beneficial to go for endarterectomy. If 50 to less than 75%, then harm is equal to benefit. So it's controversial here. And if it's less than 50% occlusion, then harm exceeds benefit and there is no point of doing it. Thrombolytic therapy is the only way out of stroke, and it has been shown to be very beneficial. What we are using is the tissue plasminogen activator, that is the TPA, the same one used for acute myocardial infarction. And there is some absolute contraindications like intracranial tumors, recent puncture at any site which is non-compressible, like lumbar puncture, for instance, recent lumbar puncture, recent stroke within the last 3 months, and even acute myocardial infarction, in which cases we are going to go ahead and use streptokinase. A recent surgery for the last 2 weeks, over the last 2 weeks, Those are all absolute contraindications. There's a very long list of relative contraindications as well, and you can find it easily at the American Heart Association, American Stroke Association websites. It's also present in Medscape in full details. So what other treatment modalities which are available for stroke other than thrombolytic therapy? It's the endovascular retriever device, and this one with a clap. That thrombectomy is performed through a device that looks quite like cardiac catheterization, but of course it reaches up to the brain and reaches the thrombus area and gets it out. Combination of both intravenous thrombolytic therapy and endovascular retriever device being studied, and so far there is no any safety concerns. Supportive management is of paramount importance. For instance, chest infection, particularly aspiration pneumonia, epileptic seizures need to be identified and treated. Deep vein thrombosis, we have to guard against this, not only in patients with stroke, but it's also important here to mention patients with intracerebral hemorrhage, in whom if they develop deep vein thrombosis, then the condition goes into more complexity because of the issue of anticoagulation, a patient who is bleeding upstairs. So we have really to guard against deep vein thrombosis by applying a hemotic device plus stockings, and all the research has shown that if both applied together, this would form the best protective measure. Painful shoulders or frozen shoulders needs to be treated with analgesia plus the physiotherapy. Pressure sores by continuous change of posture, almost Q2 hourly. Every 2 hours, the patient needs his posture to be changed. This is done by the nurses plus the caregivers. And recently, there are some beds which turn the patient spontaneously. They are adjusted in a manner that is going to turn the patient from side to side Q2 hourly. I've just seen it in the websites, but I haven't seen it in practice yet. Other supportive measures include urinary tract infection, need to be guarded against and treated, constipation, depression, anxiety. Daily physiotherapy should be done, and nutrition should be taken care of. Pressure sores, we have to fight against them by position care, since they can lead to sepsis, severe sepsis and septic shock, and increase morbidity and mortality. Social support is of paramount importance, and we have to involve the social worker looking for any social problems, economic problems. Occupational therapist is also of paramount importance. After the patient, we are preparing him to go home, we have to prepare the house for him. And it's a sort of multidisciplinary approach that would lead the patient to the best results with our patients. And with this, we come to the last slide of our talk, which is secondary prevention by antiplatelet therapy, statins, blood pressure control, and other comorbidities control, anticoagulation, and carotid endarterectomy in the appropriate patients. Thank you very much. Up next would be about zoonotic disease. Keep watching for that. Thank you.